So just trying to get it YouTube up.
Control medic 3. Medic 3. 4 back in service.
You can get real fancy in the studio. You can pull up your Dr. Schneider, can we get a test on your vote? Just test on.
Test.
It's a delay.
Oh, okay. All right.
4 back in service.
Really long delay.
Michael Pollard.
Test.
That was a delay. Wow.
Yeah, so we can just go. You can put it in studio. Are you going to get a studio mode?
Thank you.
Is this one, you need this one too?
Yeah, sure.
Thanks.
This one need a signature as well? Wasn't sure if this needed it or
No,
not.
there was just 3.
So this audit review, there's one trauma case and a couple respiratory cases, for 3 cases in all. And I always like to start off with audit review that, sometimes things go really well and they're just interesting cases. Sometimes things don't go as well as we had hoped, and they're all learning opportunities, and it's never to pick on anybody. In fact, I don't even remember who did what runs, what cases. I really don't. It just so happens all 3 of these were, as far as I know, no glaring issues. They're just very interesting and can learn from. But that's not always the case, and it's like I said, never to pick on anybody or anything like that. So we'll go ahead and get started. I think the first one's the trauma patient. All right, MVC pickup truck versus side-by-side. So EMS and fire were dispatched to an accident with injuries at an intersection via 911. Okay. Upon our arrival, 77-year-old male patient was found oriented ×1, lying in a left lateral recumbent position on the sidewalk. Patient was repetitively saying, "Sit me up," and could not answer any questions. He had a large laceration to the back of the skull. There was bone exposed, and it was soft on palpation. Laceration was also noted above the left eye. The right hand was degloved from the wrist down. A C-collar was applied. Spine was palpated. No step-offs were noted. Pelvis palpated and found to be stable. No crepitance noted in the femurs or upper arms. So Jared, I want to make sure everyone knew it's from social media. It wasn't from us that took the picture. But that's the truck. That's not the side-by-side. I don't know if the...
Side-by-side is the white one.
Is that the white one? Okay, gotcha. All right. Patient log rolled on the backboard and was secured with 3 straps and carried to the cot. He was secured with the 3 straps, 2 side rails prior to being taken to the ambulance. Once the ambulance clothes were removed, a secondary assessment was completed. Here's the kind of initial vitals, not too bad initially. He did have a deformed left ankle, an obvious flail segment to his left lateral chest. Flail segment was covered with a bulky dressing and secured with 2-inch tape, and the gloved hand was wrapped with Curlex. Lungs were auscultated and no sounds were noted on the left. Right side was clear in the uppers and decreased in the lowers. IV access was obtained in the right antecubital with an 18 gauge and 20 gauge in the right forearm. So right now, what are we thinking as far as disposition planned, initial treatments, kind of what things come to your mind just from that brief amount that we've gotten so far?
Felt like it hurt, but I didn't feel a thing.
Yeah, I mean, he's got a nasty left ankle fracture. Probably the most concerning is that flail segment of his chest. The gloving of the hand, potentially bad head injury. They can see bone. It felt kind of soft. So as far as disposition, where are we taking this guy? Yeah. So we going by ground, we going by helicopter? Yes, good. So, I mean, he meets a couple, but the biggest concern, again, for me is that flail chest. Those can go south pretty quickly, and they're not really hearing much in the way of breath sounds on the left side. Makes you worried for what kind of condition? Yeah, pneumothorax. And those can rapidly develop into what's called a tension pneumothorax, where the pressure builds up so high that you're not getting proper blood flow through the body. The pressure pinches the vena cava, and you're not getting flow. Unless that pressure gets resolved or relieved, then you can go into cardiac arrest. All right. Vitals were obtained, and patient was sinus tach, initially hypertensive, adequate perfusion. He was placed on 15 liters via non-rebreather and given 100 micrograms of fentanyl for pain. The left chest was decompressed mid-clavicular with some improvement. Transport was then initiated to Lifeline's hangar by ambulance emergently. So whenever there's a needle decompression case, I always like to review kind of needle decompression, the procedure, and then I think we did last audit review too, but like I said, whenever I get a needle decompression, I just like to review the procedure itself. But there's 2 different spots you can go. One is the second intercostal space, the mid-clavicular line. That's the most common place I use if I'm needle decompressing. Chest tube, I actually use the second location, but either one's fine for needle decompression. But basically, clean the skin. It's a big needle. It's a 14 gauge needle, like 3 1/4 inches. And What I typically try to do if I'm in a cardiac arrest situation in the ER and I'm worried maybe this person's got a tension pneumo, is I try to hit the rib in that kind of mid-clavicular second intercostal space, and then I'll go right over the rib. I'll kind of guide it over the rib. You don't want to go under the rib, which is where the artery and nerve and vein, that's where those live, and you can do some damage, cause some internal bleeding if you hit one of those structures. So I actually aim for the rib, try to hit it, and then try to guide it just right over it. This is how I typically go about it. And then mid-axillary line, fourth to fifth intercostal space, that's the most common place you'll see a chest tube placed. It's a fine place to do needle decompression. You're not going to interfere with our ability to put in a chest tube if we have to in the ER or the trauma center. It's just perfectly fine. Whatever you feel the most comfortable with. I ended up talking to our pediatric trauma folks, and I asked them, hey, with children, little babies, you know, if this were to happen where we're worried about a tension pneumo or a pneumo developing, is there a preferred spot that you like anterior or axillary? And they said either one's fine. I just said obviously be aware that you're working with much smaller spaces, so don't hub a 3.5-inch needle or 3.25-inch needle in a little child, but it's the same. There's no contraindication to go in either location with a child as well. Okay. All right, I got a couple videos to kind of show, I think do a good job with needle decompression.
The only equipment required is a 14 or 16 gauge needle. An over-the-needle catheter is best. If time permits, cleanse the skin with antiseptic solution and inject a local anesthetic such as 1% lidocaine. Although insertion virtually anywhere in the correct hemithorax will decompress a tension pneumothorax, the preferred insertion site is the second intercostal space in the midclavicular line as shown here. If the patient isn't hypertensive, cleanse the insertion site using an antiseptic solution such as povidone iodine, and inject 10 ml of local anesthetic solution in the skin, and particularly around the pain-sensitive membranes of the periosteum and pleura. Insert the needle, piercing the skin over the rib below the target interspace, then directing the needle cephalad over the rib until the pleura is punctured, usually indicated by a pop and or sudden decrease in resistance. After doing a needle thoracostomy, insert a chest tube as described in a separate video. Be sure to insert the needle over the upper border of the rib.
So, depending on your protocols, you're either going to have a 10 or a 14 gauge needle for needle decompression. The layers of the chest wall in general stay the same wherever you're at. So I've identified my landmark to hit the fifth intercostal space, anterior axillary line. First thing I'm going to hit is skin, and I can either make a small skin incision with the enhanced ARS, or I can just penetrate straight through the skin. I'm going to hit skin, I'm going to hit some subcutaneous tissue, and then as I proceed to go, I'll probably hit a small amount of muscle, and then I'm going to hit the rib, right? And I can feel that needle bouncing on that rib, and that's exactly where I want to be. Now I want to direct the needle over the rib, because below the rib is going to be the intercostal nerve, artery, and vein, and I definitely don't want to penetrate that. I can cause a nerve injury, or I can cause bleeding into the chest, which we don't want to do with our patient. Now that I'm hitting the rib, I'm going to place my finger right at the skin line, and then I'm going to back up 1, 2, 3 centimeters, and that's going to be my safety, so I don't penetrate further into the chest cavity than I need to. Now I'm going to walk it over the rib, and as I do that, I'll start penetrating through the intercostal muscles. Now the next thing that I hit is very important to feel, and that's going to be that parietal pleura. Once I hit that parietal pleura, I'm going to feel a little pop as it goes, and then I know that I've entered the pleural cavity, and I haven't penetrated too far because I'm not past my 3 centimeter mark on my needle. At that point, I'm going to stop progressing the needle. I'm going to hold the needle in place, and all I'm going to do is angle up and then thread my catheter into the chest. And that way we can safely insert it going through each of the layers from skin all the way into the parietal pleura, and still stopping short of hitting the heart once we get into the thoracic cavity. What I can do is I can take my capno spot, place it on the end, And as that air escapes, it changes color to show me that CO2 is exiting the
We don't use those, do we? I don't think we use the cap nose spots. Okay.
and it's performing as it's supposed to. So now I've successfully done a needle decompression. So what does that really do in a tension pneumothorax? Well, in a tension pneumothorax, we've got a lot of air that has entered the pleural cavity, and that expands a large pocket of air inside the chest, but it's outside of the lungs. What it winds up doing is not only collapsing that lung, but more importantly, that pressure builds up on the inferior vena cava. The inferior vena cava is what supplies blood to your heart to then pump to the rest of your body. With enough pressure, that can stop blood flow going to your heart, and that's really how you die of a tension pneumothorax. So by placing this catheter into the cavity, I now allow that air to exit the cavity to the outside. That then decreases pressure on that inferior vena cava, blood flows through it again, that lung can re-expand, and now we've got our patient doing much better than they were with that tension pneumothorax.
Okay.
All right, guys, needle decompression.
Okay, let me get back to the talk. Okay, good. Any questions about that? Either placement in the, mid-clavicular or anterior axillary line? Any questions regarding that? Okay, good. So anyway, left chest was decompressed, mid-clavicular line with some improvement. Transport was then initiated to Lifeline's hangar by ambulance emergently. And we went through that. So here were the vital signs, initially stable like we talked about, with the blood pressure, the heart rate, but as oftentimes with severe trauma, he's starting to become hypotensive, looks like and tachycardic, probably just prior to arrival to the Lifeline hangar. There's something called the golden hour of trauma. You got like an hour to really make life-saving interventions with severe trauma. And this guy's kind of showing, like within that hour of trauma, unfortunately, the body can start to not be able to withstand it and can start to, have hemodynamic compromise, and that's what we're seeing here. It could also mean that there's another pneumothorax developing, so you have to reassess the lungs. It could also mean he's bleeding to death, so again, this guy's going to need, with him becoming hypotensive tachycardia, he's going to need blood products. To me, when I see these vital signs doing this, it tells me, uh-oh, this guy's getting sick, like he's getting sick quick. This is the rhythm strip, like a sinus tachycardia to me. Okay, so during transport, lungs were auscultated, and again, no sounds were noted on the left. Decompression was completed in the left chest mid-axillary line with a 14 gauge. Again, there was some positive effect. Upon arrival to the hangar, Lifeline boarded the ambulance and care was transferred to the flight team. So, kind of want to go over what happened to this guy. He had just extensive injuries. In fact, this list doesn't catch it all. I've got a few more things that happened with him on the next slide, but he ended up having bilateral pneumothorax, bilateral bruised or contused lungs. He had an epidural hematoma. Remember that big scalp lac where there was exposed bone? It kind of felt a little soft. He had an epidural hematoma. He had a skull fracture, facial fractures, multiple pelvic fractures, multiple rib fractures, which makes sense with that flail segment. He had a subarachnoid hemorrhage, a subdural to go along with the epidural, and broke his sternum. He did not survive. Kind of want to go through exactly what happened in life flight and then upon arrival to the trauma center and the next 24 hours or so. So I got this from the discharge summary from Methodist. I was able to find, sometimes I can't find this stuff, but I found it with him. So this is kind of from where the helicopter crew took over onward. So that's per helicopter EMS, I'm pretty sure I understood that correctly. So per the Lifeline EMS, the patient was found to be combative and hypotensive. He was given epi and blood. He was then intubated. Per report, following intubation, the patient arrested approximately 3 times. We're going to be talking about, especially with the lieutenants and our captain, RSI, and that's one of the things that we really stress with RSI, and eventually it'll roll out to you guys as well, is stabilizing blood pressure and oxygenation prior to paralysis, because what can happen was happened here, and I'm sure they did. I'm sure they tried to optimize before intubation as much as possible. But what can happen is when you paralyze somebody with intubation, like I think they did, you take away a lot of their sympathetic drive, so a lot of their adrenaline drive, kind of keeping them somewhat stable. It kind of wipes it out, and you can just really crash after being paralyzed. So a big part of the talk that we're going to be giving the lieutenants and captain for RSI privileges is, hey, just making sure we've resuscitated adequately as best as possible before we consider paralysis. And that's kind of what happened here, probably despite best efforts by the EMS crew or the Lifeline crew, that when he became paralyzed for intubation, his vital signs just kind of crashed. So he was given 2 units of whole blood, 3 epi pushes, bilateral finger thoracostomies. It did result in return of spontaneous circulation prior to arrival to the trauma center. At Methodist, the patient remained intubated. He continued to be hypotensive. His systolic pressures were in the 60s. Massive transfusion protocol was initiated. Interesting, the FAST exam was negative initially. So a FAST exam is a focused abdominal sonographic trauma assessment. Pretty sure that's right. And well, they'll do an ultrasound to look and see if there's any internal bleeding in the abdomen or if there's any bleeding around the heart that needs to be like abruptly dealt with surgically. So they did a FAST exam. They looked at the heart. They looked in the belly at several different quadrants of the abdomen, and they didn't see any obvious internal bleeding. An arterial line and a central line were placed. Central line is like a gigantic venous catheter to give blood products and medications very quickly. An arterial line is a way of monitoring blood pressure very closely. It gives you second-to-second data of what your blood pressure is doing. So arterial lines, central lines were placed. Vasopressors were started. Continue to be hypotensive despite multiple blood products. So calcium and another IV push of epi were given. Anybody know why we give calcium? That's kind of a interesting one. It's correct. I agree they should have, but do you know why we give calcium there? So blood has a preservative in it called citrate. It helps prevent the blood from clotting in that little transfusion bag of blood, you know, when you hang it up. So to prevent that from clotting, it has citrate in it. Well, citrate binds calcium. It'll lower your calcium levels. So if you're giving somebody like lots of blood products, you'll actually cause them to be very dangerously low on calcium, hypocalcemic, because that citrate's binding the calcium. So if you're giving multiple units of blood, it's good to remember to give them a dose of calcium because it'll prevent them from getting profoundly hypocalcemic or low on calcium. So anyway, that's why they did it. Another IV push of epi was given with some improvement in blood pressure. He was then taken for imaging. Initial CT scans negative for active bleeding. However, patient continued to be hypotensive. Massive transfusion protocol was reinitiated. A second FAST exam was positive with repeat imaging significant for multiple blushes. Blushes are like active internal bleeding. Patient taken immediately to interventional radiology for evaluation and intervention. While in the IR department, he had a large scalp laceration with uncontrolled bleeding. I believe NUS is neurosurgery. Neurosurgery evaluated while in IR and wrapped the head with Coban for better bleeding control. Patient was on Levophed, epinephrine, vasopressin, and continued to be hypotensive. Intermittent episodes of bradycardia, ongoing blood products transfusion, multiple doses of push dose epi, or 0.2, big dose, 0.2 to 0.3 milligrams IV push epi, calcium, and bicarb. Patient had a left inferior epigastric artery, left internal mammary artery, numerous intercostal arteries, and bilateral internal iliac and small pelvic branch arteries that were embolized. So he had just multiple areas that were bleeding around the chest, the epigastric artery around the stomach, rib. Those arteries we try to avoid when we needle decompress, multiple of those arteries were bleeding. And then the iliac, so kind of in the pelvis, with some of these pelvic fractures, some of the blood vessels were bleeding. So they embolized as many of them as they could. At the end of the procedure, patient became hypoxic. His oxygenation was 80%. He was bagged. SpO2 got as good as low 90s. He was on 100%. His PEEP was increased, so positive pressure was increased to try to recruit more alveoli and increase his oxygenation. And he was transported to the surgical ICU. When he was there, hypotension and hypoxia persisted. He remained on max dose Levophed, epi, vasopressin, continuing ongoing blood products. His pupils were minimally reactive. He had no gag or cough, no purposeful movements. He had received no sedation. Remember, he had that subarachnoid, subdural, and epidural hematomas with bad brain trauma. Family bedside and patient's code status was changed to DNR. Prior to withdrawing care, he had received 4 units of whole blood, 42 units of packed red blood cells, 42 units of plasma, 7 units of platelets, 6 units of cryoprecipitate, again, Levophed, vasopressin, epinephrine, calcium, bicarb, epi, and remained on full ventilator support. However, despite remaining on maximal medical support, the patient passed away. And I don't know if that was a typo. I gotta say it probably was correct. I mean, I took it straight from the discharge summary, but that's a lot of blood. We're talking 46 units like total. And there's 10 units in the human body. So you got about 5 people worth of blood, while he was there to try to resuscitate him and save him. So I think a fantastic job by our crew. Everybody did a very good job recognizing, hey, I've got a sick one. Even though the initial vitals weren't too bad, recognize, hey, I've got a sick one here. This guy needs to go to a level 1 trauma center, which is completely appropriate. Recognized, hey, we've got pneumothorax on the left, and reassessed and said, hey, I'm not hearing breath sounds again. We need to decompress again. That's fantastic. Appropriate splinting of the flail chest. Again, multiple sites of access is advised with severe trauma. In fact, the bigger the IV, the better. But if you can get multiple sites of access, that helps tremendously. And again, properly address the degloved hand. They may have given TXA. He would have been a good candidate for it. I didn't see it in the report, but I wouldn't be surprised if Lifeline or Lifelight did give the TXA. Tranexamic acid, it helps to decrease internal bleeding, like hemorrhage. It's most effective when you give it within the first hour. It's usually a gram, like 1,000 milligrams of TXA. Most effective when given the first hour of severe trauma with hemorrhage. It's still effective given within 3 hours. Once you get beyond 3 hours, the effectiveness really, it kind of wanes off. I had a meeting with that pediatric trauma specialist. His name's Dr. Landman. He leads like the Riley pediatric trauma team. And I talked to him about TXA with pediatric patients, and they are doing it. They actually give TXA to pediatric patients with with concern for bleeding, internal bleeding, and so that will be rolling out in your protocols here soon. But just for spoilers, it's 15 milligrams per kilogram up to a gram of TXA. But it's effective in pediatric patients, makes sense, just like it would be adult, and they are using it in the pediatric world. If we had blood products, which we will, our chase vehicle at some point in time will, it's going to happen. Obviously, he would have been a good candidate for receiving blood products once he started becoming hypotensive. All right.
So our people didn't give it either?
No, but he hadn't started showing signs of like hypotension until the very end, it looks like.
You don't have to wait till you see that.
That's true. That's true. Yeah, if you're concerned about internal bleeding, and when I would have been concerned about massive internal bleeding is when you start getting that tachycardia and blood pressure starting to drop, heart rate starting to go up. That'd be like, all right, either this pneumothorax is getting worse, he's developing a new pneumothorax, or he's hemorrhaging, or yeah, I probably would have given it at that point in time. As soon as I start seeing the blood pressure dropping and the heart rate coming up, that's when I would have potentially given it. Yeah. So it would not have been wrong to given it in this instance either by us. All right. Any questions about that first one?
Do you know why he didn't go to surgery? I know he went to the surgical ICU, but...
Yeah, so I think when they took him back for imaging, they saw where he was oozing and bleeding from like chest and belly and pelvis. And I mean, I think at that point in time, your best bet's to try to embolize all these things as opposed to just ripping you wide open. And I don't think he would have survived like complete opening him up. That's my best guess. What's that?
Being 77 years old didn't help.
Yeah, that's a good question. That's my best guess, is that there were areas where like, okay, these are amenable to embolization. We think our best bet with this guy who's really unstable, he's probably not going to survive surgery given the fact he's on 3 pressors and still hypotensive. His best bet's interventional radiology is much less invasive to try to embolize these vessels, which are amenable. There's a lot of the vessels bleeding, but they're all amenable to embolization. That's my best guess. If his vital signs had been a little bit more stable, maybe they would have opened him up and tried, but yeah, I suspect that was the problem, was that he was just too unstable to go to surgery and survive it. Yeah. All right, any other questions about that first one? All right, so case number 2 and 3 are more respiratory driven as opposed to trauma. So dispatch the home residence for reported breathing problem. Chief complaint is shortness of breath. So 68-year-old male, he has a history of high blood pressure, diabetes, he takes diabetic medication, glipizide, takes a thyroid supplement, levothyroxine, bupropion, which is Wellbutrin, lisinopril and metoprolol for blood pressure. He takes a atorvastatin for cholesterol, another diabetes medicine, metformin, and amlodipine for blood pressure. He presented with shortness of breath. Onset of symptoms were 5 o'clock, on August 2nd, 2026. So no known allergies reported, no indication of injury. On scene, the patient is located sitting on his couch. He's not on any home oxygen normally. He reports that he's been having a hard time breathing since 5 o'clock, and it's now midnight. He's speaking in short sentences. He's placed on the monitor and a non-rebreather right away. Medications are confirmed. Stair chair is brought in. The patient transferred with assistance to the stair chair and is brought down to the cot. Patient's once again assisted in a stand and pivot maneuver to the cot. Once in the cot, he's moved to the back of the ambulance where lung sounds are assessed. The patient's known to have decreased lung sounds with mild inspiratory wheezing. Patient's continuing to work to breathe and reports that the oxygen doesn't feel much better. Patient's given a duo neb to use. So, yeah, what kind of things come to your mind as far as this guy? It sounds like he's struggling. He's talking in very short responses because he's so short of breath. That's one thing that makes me worry. Whenever I have a patient that's short of breath, if they're talking to me in full sentences, I mean, don't get me wrong, I'm sure they're still short of breath, but it makes me feel much more reassured. When they're talking 2-word sentences, so short of breath, that makes me much more nervous. And that's kind of what it sounds like this guy was somewhat doing. He was short of breath. They're not hearing much, they're having decreased lung sounds. If I'm hearing a lot of wheezing in a weird way, that's a little bit better than not hearing much in the way of any lung sounds and hearing just a little bit of wheezing. Because when you're not moving air well at all, you'll hear a little bit of wheezing and not much in the way of lung sounds. So again, they're noticing decreased lung sounds, a little bit of wheezing. I bet this guy's actually really tight. I bet his lungs are really tight. So duo neb is one obvious option for him. So albuterol and Atrovent. What other kind of options do we have available for this guy with his wheezing? We're hearing lung sounds. They're decreased, but we're hearing them.
Epi.
Yeah, so epi, if I always say if everything else is failing, then go for the epi. But you're right. So epinephrine is an option. It'll help to dilate the tubes of the lungs, the bronchioles, the bronchi. So that's definitely one option that may be necessary with him. Kind of depends on how things go. Yeah, so solumedrol, it's a steroid. One of the best medicines we have to try to decrease inflammation and relax the lungs. The only problem with solumedrol, it's great medicine. It takes hours to work. I mean, give it, don't get me wrong, but it takes 2, 3, 4 hours to work. So I wouldn't give solumedrol and be like, okay, in about 5 minutes he's going to be looking. No, it doesn't work that way. It's going to take a few hours, but it's still important that he gets it as soon as possible. So yeah, solumedrol, we got the duo neb. What else could we potentially give this guy that's kind of in bad shape with wheezing? Yeah, so MAG, the typical dosage we like to use in the ER, and I think it's the same in your protocols, I'll check, is 2 grams over 20 minutes. And the way magnesium works is it's a smooth muscle relaxant. So for example, if you want to stop a pregnant woman from having uterine contractions, give her a bunch of magnesium because it stops that smooth muscle uterus from contracting. Well, the same thing happens with the smooth muscle around the lining of our lungs or our airways. When there's an asthma or COPD attack, those muscles, they constrict and the airways get narrower. If you give them a big slug of magnesium, it relaxes those smooth muscles and it opens up the airway. It's much more effective in asthma than COPD. I still use it for COPD. I use it for both, but it's very effective in asthma. I still like it in COPD, not typically as effective, but I will still use it. So yeah, magnesium, yeah.
We were discussing it in class down in Madison a couple weeks ago. Would you you happen to know what a standard dosage for mag sulfate is for nebulized for COPD?
I've never done it nebulized. I actually looked it up. It can be given that way. I've never done it. I was always taught and always given it IV. So I don't know the answer to that. And we give it IV here, and that's what I would encourage you. That's how we do it in the ER. I know it exists. I've never witnessed a mag nebulized treatment. I've never seen it with my own eyes. So I'm not saying it doesn't exist, not saying it can't work. I've never seen it. I don't have an answer for your question on that one, sorry. So good, magnesium, solumedrol, duo-nebs, epi. Anything else with this guy that's in potentially pretty bad straits with his breathing?
I'd ask if he's ever been intubated before.
Yeah, that's a good question because that's one that we ask all of our wheezing patients. It just changes the ballgame of how severe this may get. So if they say, oh yeah, I've been intubated 3 times for this, well, this is going to be pretty bad. Most likely, it's going to be pretty intense respiratory distress with this guy. So it's a good question to ask. Any other treatments that we could try with this guy or interventions that may help his work of breathing, help him breathe easier?
Did you say CPAP already?
No, yeah, so there it is. So CPAP was the one I was trying to think of, read my mind kind of thing. So yeah, CPAP can be used in addition to the duo-nebs to try to help decrease the work of breathing. The CPAP stents open the alveoli, it stents open the smaller airways, increases gas exchange. As long as they can tolerate it, some people just hate the positive pressure, but as long as they can tolerate it, it definitely decreases work of breathing. It will help to improve oxygenation. All right. So I really just wanted you to look at the first vital sign. They're kind of all on there, but the initial vital signs, the blood pressure looks okay, the heart rate's okay. What do we think about that respiratory rate? Yeah, that's fast. He's breathing fast. Anything over like 16, normal's around 12, so anything over 16 is kind of quick. 28 is very fast. And obviously 87% on room air is not normal. So especially if you're breathing that fast and you're 87% on room air, that's not normal. The patient is coached through the use of the duo-nebs and does well at first. The patient is given an IV and a 12-lead EKG is placed. Noted to begin shaking and bearing down while using the nebulizer. Hey, what do you think about this EKG? Especially like V4, V5, V6, even leads 1 in AVL. What kind of strikes you as odd about those leads? Yeah, that's impressive, ST depression. That's like over right about 5 millimeters of ST depression. That's a lot.
Would you do a posterior or a 15?
You could. You hope what's going on here is that the heart is not liking the hypoxia, and you're seeing like an ischemic pattern from hypoxia. It's kind of what you hope. What it could be is a blockage, like a pretty substantial coronary artery blockage. This is not a STEMI, by the way, but it could indicate a pretty significant coronary artery blockage that's not dealing well at all with even very mild hypoxia. So this EKG tells me this guy may have some pretty severe coronary artery disease. This could progress to STEMI pretty easily. It could also potentially progress to STEMI pretty easily. So if I saw this EKG, I'd be getting a repeat in the ER setting and making sure it's not changing. And then my hope would be, as I address the hypoxia, I address the work of breathing, stabilized him, that those ST depressions would improve, would be my hope. But yeah, that's a sign of ischemia, so decreased blood flow to the heart, or oxygenation to the heart, blood flow oxygenation to the heart. It could very easily progress to infarction, which, ST elevation. So yeah, that's a concerning EKG right there. The patient is coached through the importance of relaxing as much as possible while utilizing the nebulizer, continues to attempt to bear down and shake with force. I'm not sure what that's all about, but bear down and shake with force. The patient is coached through it. He begins to improve. His oxygen saturations increase to the mid-high 90s. He's given a dose of solumedrol like we talked about. Again, won't work immediately, but very important. It'll the sooner the better with that salumedrol. Begins to experience a coughing fit, is coached through it. O2 sats drop precipitously. That will happen with coughing fits. They'll kind of drop and they'll come back up. But down to the 80s, and the patient begins to attempt to talk. When he begins to attempt to talk, however, is unable to say more than 1 to 2 words at a time. Patient is coached through the placement of CPAP. He tolerates the placement. Given a second dose of albuterol through the CPAP, that's great. 2 grams of magnesium mixed up and started, that's great. Coached through the CPAP, he begins to relax. His heart rate is slowing. Oh, slowing his rate of breathing, I mean. Yeah, at this point in time, I'd like to see what a repeat EKG looked like because he's more relaxed, his oxygenation is stabilized, he's looking more stable. Be kind of curious. So these are all the treatments. This is a great approach to like a really bad COPD or asthma attack. And then could we have given epinephrine? Sure, I think we could have. He was severe enough, but he was stabilizing. I think we're okay with holding off on epinephrine as well. EKG rhythm is noted as artifact. Again, I would argue there was some pretty good ST depression on there. Respiratory failure, secondary impression of acute respiratory distress. Transported to our facility, was moved to the ambulance via stretcher.
Go back to his vitals where it showed the,
Yeah.
Is that oximetry? Well, it's 88, it's not that bad, I guess.
Yeah, no, you're right.
Is that sometimes from
The CPAP can go all the way up to 100%, right? You can put them on 100% FiO2 CPAP. So, yeah. I don't know exactly what the settings on the CPAP were. I didn't see it written in the report. So, in the ER,
That respiratory rate to have gone up that much?
yeah, that's true too. So, yeah, you would have expected him with it being more calm to kind of the slower the respiratory rate. No, I'm with you. That is kind of odd. I didn't catch that. But yeah, I would have expected his respiratory rate to go down, not up. I think I got this in the correct order. I don't think it's reverse order. I think it's correct.
But I mean, if he's getting more relaxed and you're getting...
Yeah, you'd think your respiratory rate would go down, not up. Yeah.
Go off and-
I'm with you. Now, I'll always kind of take how they're looking. Like if they're looking improved, but yeah, I'm with you. I would have thought that would have gone down.
Don't you sometimes see the oxygen saturation not respond, like the pulse oximetry not be as good because the CPAP's not allowing off-gassing, so when you put in a BiPAP, it like immediately will jump up because you're getting rid of the CO2.
One more time. So you put them on the BiPAP and what?
So if they're on CPAP for very long, you're constantly pushing air in, so it's hard to off-gas, so you don't get rid of your CO2, which is displacing oxygen, and then you put them on BiPAP, and it goes from like 88 to 98 just in minutes.
Yeah, so I think BiPAP probably is a better way to oxygenate and ventilate, to your point. It's kind of a bigger piece of equipment that won't fit very well on the trucks. In fact, I tried to transport a patient on BiPAP once, and I don't think we had a way of getting it to fit on the truck, if I remember correctly. It was something like that. So I could see that happening, Philip. That's possible. So BiPAP, the way CPAP works, it continuously gives you pressure, like continuous positive airway pressure. That's what CPAP means. And I think ours goes up to 10. Is that right? 10 is CPAP, I think. 10 pressure. So BiPAP, the way it works is it also will deliver continuous pressure, usually a little bit lower than 10, maybe like 5 of continuous pressure. But then every time you take a breath, the BiPAP machine can identify, oh, you're trying to take a breath, and will deliver increased pressure while you're taking a breath. So when it recognizes you're taking a breath, it may deliver you 15 millimeters of mercury of pressure. So it's like, and it just kind of briefly like helps to force extra pressure into you, and then very quickly goes back to that continuous pressure of like 5. So it basically just further assists you during inhalation for breathing. And in doing that, you can lower the amount of continuous positive pressure support, and to Philip's point, help you exhale a little bit better. So anyway, that's the difference between the CPAP and the BiPAP. So when he got to the ER, the ER physician said, yeah, I'm concerned about hypercarbic, which means too much CO2. That's what we off-gas, what we breathe out. Hypoxemic, low oxygen, respiratory failure, concern for COPD exacerbation, Could this be a pulmonary embolism? Maybe. We don't know yet. This is just like the initial thoughts of what could be going on with this guy. Could this be congestive heart failure, pneumonia, bronchitis? I would out on acute coronary syndrome for this guy because that EKG, that was really a bad-looking EKG. He has upon assessment by the ER physician, he has very poor air movement with wheezing, and he suspects primarily a bronchospasm process, and I would agree. He's on continuous nebs, placed on BiPAP. Workup breathing has improved on his initial measures. Evaluation will include a D-dimer, which looks for clot, troponin, which again looks for evidence of ischemia or infarction, a repeat EKG, a chest X-ray to evaluate for either pneumothorax or infiltrates, stuff like that. Patient improved with the BiPAP and the nebulizer therapy. X-ray looked like pneumonia in the right lower lung. He was covered with antibiotic called Zosyn. CT scans were obtained. He has a little bit of fluid buildup in his lungs. Those are called pleural effusions, and some thickening, which again, those fluid collections could be congestive heart failure as well. He gave them Lasix, which helps to diurese, get the fluid off the lungs. He was on BiPAP and able to be weaned off the BiPAP to a nasal cannula while in the ER. So apparently he rapidly improved while in the ER. My guess is the treatments, the Solumedrol finally start kicking in, that kind of stuff. He was discussed with the hospital service and will be admitted to the medical step-down unit. Patient was discussed with the on-call cardiologist. That EKG, again, looked really concerning with those depressions. He did not meet STEMI criteria. Troponin, so the troponin was high. Troponin's a heart-specific protein that will become elevated if something has damaged the heart. It's difficult to interpret in his case because hypoxia can also cause troponin to go up. But his troponin was increasing, they checked it once, they got a number, it was elevated. They checked it again like an hour later and it's going up. And that's kind of concerning too, that it's trending upwards. So there was concern of a potential primary cardiac issue. He was given aspirin and he was started on a heparin drip to, if there is a primary cardiac issue, it'll hopefully decrease the amount of damage. So again, COPD exacerbation, pneumonia with sepsis, hypoxemic respiratory failure. He ended up having a heart cath that showed, I think, a couple of blocked vessels. His left anterior descending and his left circumflex had significant stenosis. So there was debate, do we do, bypass surgery, do we do stenting? There was kind of debate with cardiothoracic surgery, which one's best, and they ended up opting for stenting with this guy. There was a component of congestive heart failure. He got multiple doses of Lasix. He's actually on a Lasix strip for a short period of time. And then to top it off, they apparently ultrasounded his neck, and he was found to have a critical carotid stenosis. So vascular surgeons want to get involved as well to kind of open up his carotid artery that was blocked on the left side. So yeah, really sick guy, really good example of severe COPD or asthma. I think with him it's more COPD, but basically bronchospasm. A good example of severe bronchospasm, and I think good management of it as far as the treatments, the duonebs, the Solumedrol, the magnesium, the CPAP. Definitely we could have done epi. In fact, if he was still hypoxic, I probably would have. If I was on max CPAP and I was giving him nebs through the CPAP, he'd already gotten Solumedrol, he'd already gotten the mag, and I was still like hypoxic, I probably would have given him epi, honestly, and seen if that would have helped open him up more. So I know this wasn't quite asthma, but it just kind of gave me an excuse to talk a little bit about asthma, and then we'll talk about COPD as well. So asthma and COPD, they're similar in the fact that they both cause wheezing, they can both cause respiratory distress. The main difference in my mind is that asthma is typically completely reversible. Like your lung tissue itself is fine, your airways are typically okay until they become irritated. Whereas with COPD, that's not the case. You've got like permanent damage to your lungs, your airways are kind of always thickened. They do flare up and get worse, but there's a degree of permanent damage there with COPD. That's not the case with asthma. Asthma, as long as they're not having an attack, their lungs are pretty normal. So chronic, non-progressive lung disorder, there's this increased airway responsiveness. So that could be a response to an allergen. It could be a response to a virus. It could be a response to ammonia. There's a thing called cardiac asthma, where if there's fluid buildup in the lung tissue from CHF, it can cause you to wheeze. So something that's irritating the lungs, that's making it constrict, the airways constrict. Get airway inflammation, but it is reversible. You can reverse the airway obstruction with the medications we talked about. Whereas with COPD, you can improve it, but it's not going to be completely reversible with COPD. Can occur at any age, but more common in children and adolescents. 50% develop asthma before the age of 10. It is increasing. Most common predictor, like Philip was talking about, of fatal asthma is prior history of intubation.
Does asthma kind of act like allergies and can come and go? So it may develop as a child, will it disappear?
Yeah, some people do grow out of it. They'll have childhood asthma, and then as they get older, it kind of subsides. I don't know if it ever completely goes away, but just your airways don't become as twitchy, I guess. And as we get older, our airways get bigger, right? So if you're a child and you have small airways and they're getting irritated, it doesn't take much narrowing before you're really going to know it and feel it. Whereas when we become adult-sized, your body can tolerate a little bit more swelling. So that's also why maybe people grow out of asthma. They may never really grow out of it. They're just airways get bigger to the point where they don't feel it as much, if that makes sense. Yeah. So, and then some people, like myself, never had wheezing their whole life, and they turn 40 and they get wheezy with viruses. So yeah, I don't know how to make sense of that one. So asthma, again, we talked about this, infections, allergens, certain medications can do it to anything that really irritates the lungs. That's what we're looking at, something that's irritated the lungs. Releases all these inflammatory mediators. It causes airway constriction. This is what we're fighting with our medicines, by the way. Airway constriction, mucus production, and airway edema. All of our medications, all of our interventions, our CPAP, it's targeted at these three things: mucus production, airway constriction, and edema. Trying to reverse that process. So again, every patient, every time, secure the ABCs, give them oxygen if hypoxic, transport without delay, place on the monitor, and then we'll talk about we already talked about the medications. We'll go one more time. So why does albuterol work? It promotes dilation of the very small peripheral airways, and it increases mucus clearance. So that's like a dual positive effect. We want to clear out the mucus, and we want to dilate all of the airways, so the peripheral airways included. And it works quick. I mean, we're talking less than 5 minutes it starts working. Atrovent or ipratropium, it targets your larger airways. And again, we want to dilate the large one, we want to dilate the small ones. And it decreases mucus production. So albuterol helps to clear mucus out. Ipratropium or Atrovent helps to decrease the production. So again, we're attacking this in multiple different ways to try to reverse this constriction, mucus production, edema process. Its onset of action is a little bit longer, 30 minutes. If you give them together, they actually help one another. So albuterol and Atrovent have a synergistic effect. Albuterol will make ipratropium more effective, and ipratropium will make albuterol more effective. So that's why we oftentimes will give them as a duo neb. Steroids, again, they take a while to start working, but they're great. This is probably the most potent medicine we have. It just takes time for them to work. But they reduce inflammation, swelling, and mucus production in the airways. They increase the responsiveness of your albuterol, so your beta-adrenergic receptors that you're targeting with your albuterol, it increases their responsiveness. And again, onset of action about 3 hours, peak onset about 6 hours, roughly. And we talked about, we have CPAP. You can really improve somebody's respiratory dynamics, decrease their work of breathing with CPAP. So severe asthma exacerbations, no exception. You can also use it for a severe COPD, CHF. All those are good indications. When would you not want to use CPAP? If somebody, give me a couple examples of when you're like, man, I'd love to, but I can't use CPAP with this person. Yeah, if you're worried about pneumothorax, you're exactly right. You don't want to do CPAP. You can make it a lot worse. What other? Yeah, if they're just not going to keep it on and they're just like ripping on it and they're just getting all agitated and they're making their breathing worse, then yes, that's another good example, correct. Yeah, so especially if they're like obtunded. So if they're like, hey, stay awake, hey, wake up from, you really shouldn't use CPAP in that kind of situation, because what can happen is they can Oh, why would you not want to do it in that situation? What are you worried about could happen?
Aspiration.
Yeah, they could vomit or aspirate, and there's no warning. If you got somebody that's awake enough, they're like, they can. And I always tell people before I put on the CPAP, I was like, listen, if you think you're going to throw up, you take that thing off, okay, and we'll come help you out. And I kind of show them what to do if it. But yeah, if you got somebody that's awake, they can at least they can tell you, or they can physically like remove the mask if they're about to throw up. But if you have that CPAP on them and they throw up, all that vomit's going straight into their airway, like it's going in their lungs. So that's why you don't want to put CPAP on an obtunded or nearly obtunded patient. Is if that person, if we knew they weren't going to vomit, it's fine. I don't think you're going to hurt anything. But there's no way you know that they're not going to vomit. So that's why we don't do that with an obtunded patient. All right, good. Now we talked about this. So CPAP, COPD, asthma. Yeah, it helps with pneumonia too. CHF, like you're talking about, trauma, you gotta be a little bit worried. If you hear good breath sounds with severe trauma and you wanna try CPAP, you could, you just gotta be very cognizant that they could potentially develop a pneumothorax. Vomiting, again, you can't use it with vomiting, it can cause aspiration. If they're obtunded, again, the worry is aspiration. CPAP, not a substitute for intubation. If they're in frank respiratory failure, you got to intubate them. We talked this a little bit. So epinephrine, it's kind of like throwing the kitchen sink. You know, everything else I've tried and I'm not getting improvement. I'm going to give them a dose of epi. It'd be 0.3 milligrams sub-Q or IM. I like IM, but either way, sub-Q or IM. Before we had albuterol and Atrovent, like years and years ago, this was the treatment. I mean, if you were having an asthma attack, you got a shot of epi, and it worked. I mean, it would help. It would help their work of breathing. Now the albuterol Atrovent, it's much more directed to just the lungs. It's much more effective in my opinion. But this was a very effective treatment for many years for asthma attack, was to give them a shot of epi. Yeah, so this is very true. So intubating an asthmatic or COPD patient, it is very dangerous. Do you guys know why? There's a couple reasons why. Yeah, I had it written on here. So when you are really tight and wheezy from asthma or COPD or whatever's causing it, it takes extra amount of time to exhale. And if you have somebody who is intubated and you're bagging them, they're probably, I mean, they are like really sick. And, you know, my adrenaline, your adrenaline, it's just natural. It's going to be up. Like you're dealing with a really sick patient that you just intubated. And it's almost instinct of, I want to give them oxygen. I want to give them oxygen. I'm going to bag them up. I'm going to bag them up. I want to give them oxygen. And you got to be careful with these people, because if you don't give them time to exhale, if you give them a breath and you don't give them enough time to exhale and you give them another breath, and you don't give them enough time to exhale and you give them another breath, their lungs are just getting bigger and bigger and bigger and pop. And it's a pneumothorax, okay? So I always, in these kind of stressful situations with a respiratory failure, bad asthmatic or bad COPD, I'm always kind of aware, and I'm talking to the respiratory therapist, I'm like, just be slow. It's okay, just give them a breath, give them time to exhale, give them a breath, give them time to exhale. I don't want to give this person a pneumothorax. In any patient with severe asthma, COPD, frequent reassessment of the lungs to make sure they're not developing a pneumothorax. So that's the big one, is potential for breath stacking and pneumothorax. I once had a patient that really bad asthma attack and intubated them, and I left the room, and the nurse came and grabbed me about 15, 20 minutes later and said, hey, the patient's getting really hypotensive, and the oxygenation's starting to drop a little bit. And my thought was, oh, geez, probably developed a pneumothorax. So I go in, and the first thing I notice is the chest is like huge. And the respiratory therapist is like struggling to bag. I'm like, whoa, stop, just disconnect. Just disconnect the bag. And they disconnect the bag, and it was like the longest exhale you ever heard in your life of this person. And the blood pressure like whoosh, immediately came back up, and then the oxygenation immediately improved. I was like, you gotta go slow. You gotta go easy with these folks. You can't just like, you know, so it's just a newer respiratory therapist that was just, you know, it was a sick patient, just adrenaline, you know, you just gotta be cognizant of it. All right, I've got a neat video on asthma. It's a short one, but it's kind of a neat video I was wanting to share with you guys.
An asthma attack happens when you're exposed to an allergen or some other trigger, like a virus, cold air, exercise, stress, or environmental pollutant.
Just a second. What'd I do, Daryl? There we go. All right, we'll go start over.
An asthma attack happens when you're exposed to an allergen or some other trigger, like a virus, cold air, exercise, stress, or environmental pollutant. Your airways become inflamed and swollen, and the muscles in your chest tighten. Your breathing tubes become narrow and make extra mucus, making it hard to get enough air into your lungs. Your airways start to overreact, causing spasms that lead to wheezing and coughing. A severe asthma attack can cause shortness of breath and a tight feeling in your chest. Your skin may pull in slightly between your ribs. You may have hunched shoulders and strained abdominal and neck muscles. Your face and lips may have a blue tint. And you may feel confused, agitated, or unable to concentrate. A severe asthma attack can be life-threatening. If your symptoms aren't improving with home treatment, see a doctor right away.
All right, so it's
Hereditary TTR.
All right. Here we go. Maybe? Yeah, okay. Okay, any question about asthma or that respiratory slash non-ST elevation MI slash heart failure patient of that second case? Slash pneumonia. All right. So, all right, good. Third one, again, respiratory distress. 60-year-old, difficulty breathing upon arrival, sitting on the couch in the living room of the residence, tripod position with significant respiratory distress. So whenever I see somebody truly in a tripod position, that makes me nervous. That tells me they're struggling, because most people, their normal sitting is not like this, you know? That's usually if you're really trying to use every tool possible, every muscle possible to increase your lung capacity. That's what that tripod position is. I always get nervous every time I see somebody in that position. I'm like, oh, this person's really, really struggling. They're really working to breathe. Chief complaint, I've been struggling for 3 days to breathe. Patient says she's been struggling to breathe for the last 3 days. She does have significant COPD history, had a lack of appetite over the past 3 days, and say that she has also felt unwell. No fever or any other recent illnesses aside from struggling to catch her breath. She felt as if she was getting tired and decided to call 911 for evaluation and transport. She's awake and alert. Skin was cyanotic and pale, but warm and dry. Pupils were equal round reactive. Worker breathing was labored. Accessory muscle usage noted. She was in a tripod position. Lung sounds were diminished, and in the lower lobes and upper lobes. Unable to be clearly heard, okay, in the lower lobes. Patient again had denied any fevers and denied any recent injuries. So again, we've got a little bit of a fast heart rate, 101. 24, anything above 16, I consider fast. So 24 is definitely fast. That's a low oxygen, 80% oxygenation. So she's on home oxygen 4 liters at baseline. Attempted to use her bumetanide with no help. I think that's a steroid inhaler. Attempted to be placed immediately on CPAP, but was initially adamant that she did not want to be placed on the CPAP. Vitals were obtained, tachycardic, profoundly hypoxic like we saw. Explained that it would be essential to place her on CPAP. She finally agreed and placed it on her face. 2.5 milligrams albuterol, half a milligram Atrovent were administered via the CPAP. She's then helped to a standing position, pivoted onto EMS cot, secured to the cot, taken to ambulance for further assessment and transport. Upon entering the ambulance, she was placed on the 4-lead EKG and found to be in normal sinus rhythm. There was concern for some peak T waves. What would peak T waves, if there truly was peak T waves, what would that make you nervous about? Yeah, that's right. So high potassium is a common cause of peak T waves. There's other things that can do it, but that's the big one that we really worry about. Was then placed on a 12-lead EKG and confirmed to be a normal sinus rhythm and noted peak T waves and T wave inversion in V1. So here's the EKG. I'd argue these T waves really aren't that bad. Whenever I think about a true peak T wave, I think about it being so pointy that if it was real and I touched the top of the T wave, it would poke my finger and make me bleed, like the tip of a needle, like it's that pointy. So not too bad. And T wave inversion in V1, that's pretty normal. This is a pretty good looking EKG. I think I see what they're talking about, but that's a normal finding to have a T wave inversion in V1, and then in the left antecubital fossa. It's flushed, tegaderm, solumedrol given through that IV site, 125 milligrams, that's perfect, and then flushed. Transport emergent. Patient's vitals were obtained per unstable patient protocols. Oxygen saturation was noted to be greatly improved along with skin color and condition. She no longer had accessory muscle usage, lung sounds improved. That's mostly that CPAP, by the way, like helping her work of breathing. While patient was noted to have improved lung sounds, patient's lung sounds were still slightly diminished throughout. Care report was called to the receiving facility. So, yeah, taken to the exam room, slid from the EMS cot to the hospital bed, and then given to the receiving nurse. So, duo-neb, CPAP, oxygen, solumedrol. Anything else we could have done with this patient? Intervention-wise treatment? I'm not saying you had to, but anything we could have done? Yeah, magnesium, that's my thought. I mean, we could have done magnesium. You don't have to. And in COPD, it's much more debatable, honestly. I still like it. I still think it works. You don't have to. This patient was improving, so you can make a good argument to not need to do that because she was improving with the interventions. But definitely if she was not improving, I probably would have done magnesium, 2 grams over 20 minutes. If she was not improving, you could have considered 0.3 of IM epi as well. But she was improving. So I think it was very good care. So, yeah, the oxygen, the duo-neb, the CPAP, IV access, solumedrol, all that's great stuff. The EKG, and I like it. So there was a concern, whether it was valid or not, but there was a concern on the EKG. So definitely get a repeat. If you see something you don't like and you're worried about it, get a repeat. Make sure you're not seeing what's called like dynamic changes. Make sure you're not all of a sudden seeing like ST. If you saw that ST depression like on our prior patient, you repeat it, you might see ST elevation. If you're seeing something that has you nervous, by all means repeat the EKG. It's okay. So I like the fact that they identified. They identified something they were concerned about. Now I think it was probably okay, but they did the right thing. Is like, okay, I'm going to repeat this and make sure nothing's dangerously changing. That's how I read it anyway. All right. Diagnosed with severe COPD, so while at the hospital, diagnosed with severe COPD exacerbation with hypercarbia, which is too much elevated CO2, and hypoxemia, which is low oxygen respiratory failure. She was placed on BiPAP for 3 hours. She was given an hour of albuterol and atrovent nebs, 2 grams IV magnesium over 20 minutes, and then doxycycline antibiotic. Tried to take off the BiPAP, but she began to worsen again, so she was admitted to the ICU on BiPAP. But the CPAP you guys did probably saved her from being intubated, so honestly. So she was diagnosed with acute on chronic hypoxemic hypercapnic respiratory failure, acute COPD exacerbation. Apparently she's pretty frail because the pulmonary cachexia means you're like muscle wasting from bad COPD. She's on 4 liters nasal at baseline, required BiPAP in the ER, received the duo-nebs. Procalcitonin, which is a blood test to look for evidence of bacterial infection, was normal. That makes pneumonia not impossible, but makes it much less likely. They did check cardiac enzyme troponin to see if there was any evidence of like heart attack with her, and that came back normal. chest x-ray didn't show any obvious like pneumonia or infiltrates, no pneumothorax, which is good. She was given several medications, continuing nebulizer treatments, and inhaled corticosteroids, and long-acting beta agonists, and long-acting muscarinic agonists. That's a fancy way of saying albuterol Atrovent. And then inhaled corticosteroid, that's like that budesonide. There's lots of different types that you can do an inhaled corticosteroid. I don't remember which one she was on. She got the solumedrol en route. You guys did great. They continued that treatment while she was in the hospital. With COPD exacerbations, they still like to give doxycycline for the chance of bacterial bronchitis. So she got doxycycline for 5 days. And then HO2 eval showed that she still requires 4 liters at rest, but it needs to increase to 6 with activity. And she's to follow up with one of the pulmonologists in the near future. So COPD, we already talked about it, but I got a couple slides. So again, on the right is normal airway, and on the left is like a COPD. And COPD is kind of broken down, chronic obstructive pulmonary disease. It's broken down to really 2 processes, chronic bronchitis and emphysema. And both of those together make up COPD. So emphysema, you've got actually destruction of those alveoli, of those, the sacs where gas exchange happens. Whereas in asthma, for example, you do not have that kind of destruction. They're still normal. And with COPD, you've always got this swelling, kind of thickened airway, but it can become more tight, more exacerbated with an irritant. But it's always chronically swollen, and you're always chronically having a little bit more mucus production with COPD. By far the most common cause of COPD is cigarette smoking. There are other conditions that can do it, but that's by far and away the most common. That's why he's holding a cigarette in that picture. All right. So again, chronic bronchitis, airway hypersecretion and inflammation. It's kind of always there. It can flare up, but it's always there. And then emphysema, irreversible enlargement of the air spaces. I sometimes have people that are smokers tell me, well, I've already got the COPD, I might as well just there's no reason to quit smoking. That's completely wrong. You're just continuing to kill more and more alveoli if you continue to smoke. And then asthma is a little bit different. It's airway hyperactivity, and it does cause inflammation, but it's reversible. Your lungs go back to normal. They will not go back to normal with COPD. You'll always have a degree of damage. Causes, smoking, cystic fibrosis. If you have recurrent exposure to environmental pollutants, it can potentially cause COPD. Yeah, recurrent lung infections, that's true. For whatever reason, you're like always getting pneumonia, that can do it too. Anyone take a guess? So the alveoli are those little tiny sacs where gas exchange happens. Anyone want to take a guess how many alveoli the average pair of human lungs have? Don't Google, don't cheat.
100?
Okay, we got 100. I'll give you this, it's more than 100.
A couple thousand.
Okay, it's more than a couple thousand.
10,000.
It's more than 10,000.
500,000.
More than 500,000.
3 million.
More than 3 million.
Good Lord. What's the diameter?
Infinity.
Oh, I mean, it's so small you'd have to have a microscope to see like the diameter of one alveoli. It's not infinity, it's lower than that.
A billion.
Lower than a billion, it's a half a billion. Half a billion alveoli in your lung. Average. Some people have a billion. Some people have 3 to 400 million. On average, around 500 million alveoli. And then again, with cigarette smoking or some of these genetic conditions like cystic fibrosis or just repeated environmental pollutant, that'd be something really terrible. But it destroys those alveoli, and once they're gone, they're gone. You're not getting them back. They don't recover. So you got a half a billion of them to work with, but that cigarette smoking, it kills a bunch of them. Okay.
And how many do you need to survive?
Yeah, I don't know. It's a good question. So people can survive on one lung, so I'd say well under 2.5 or 250 million, but yeah. So COPD treatment, that's why the two kind of get confused, or the treatment is really very similar. It's oxygen. The goal SAT's 99.4% with COPD. I try to avoid 100% SATs because you can sometimes affect their respiratory drive if you get them like all the way up to 100%. but I usually tell the nurse to shoot for like 94, 95%, something like that when I'm treating a COPD exacerbation. Again, albuterol, it hits the small peripheral airways, it increases mucus clearance. Atrovent dilates the bigger airways, decreases mucus production. Steroids decreases inflammation and edema. That's what we're trying to do with these asthma and COPD attacks. CPAP decreases work of breathing. It reduces what we call atelectasis or collapsed lung from these exacerbations. It helps open the alveoli, the ones that are still surviving, and then improves gas exchange, indicate for a severe exacerbation. Like we talked about, don't use CPAP if there's active vomiting or they're obtunded, because you can cause aspiration. People with COPD typically do not respond to treatment. They do, it's just not as well as like an asthmatic. Like you can have an asthmatic that looks terrible and you give them these treatments and they look great. And that does happen. Now sometimes it doesn't happen that way, but it does happen where they look great. COPD is usually more subtle. They'll get better, but it's not rapid, it's slower. But in my experience anyway. That's all I got, guys. Anything?
Hey, a question, Dr.
Yeah.
Snyder. So like somebody that's having difficulty breathing, like severe COPD emphysema case.
Sure.
Do you guys generally give IM epi shots or subcutaneous in the ER, or do you do it?
Not very often. Again, in me, it's like a last resort thing where I'm trying to not intubating a severe COPD. It's bad for bad's not the right word. It's dangerous for multiple reasons. One, again, you increase their risk for like a pneumothorax, and two, it's really hard to get somebody off the ventilator if they've got bad COPD. So when you get them admitted to the ICU, it's really difficult. So I try, if at all possible, not to intubate severe COPD if I can, and in trying everything I can not to intubate, sometimes I'll give them a shot of IM epi.
I think maybe you didn't hear me well.
Yeah.
Epinephrine, the IM epi.
Yeah. So I will give it occasionally if I'm trying everything I can not to intubate somebody. I'll give them IM epinephrine. Yeah.
So for some reason, a couple days ago, there was an accident. It was yesterday. They had a pretty severe difficulty breathing, and this guy was not doing well. They did all the medications. They did MAG and epi. When they got to the ER, the staff was like freaking out. They gave him IM epi.
Oh, well, haven't talked to me. But no, it's again, it's not used often. In fact, I probably only do it once or twice a year. But it's not, no, it's not like out of the realm of weird. You know, it's used.
Ironically, I saw him walk up to Billy and say something. He's like, yeah, that's standard EMS practice.
I'm going to send you that around probably later today.
Okay, sure, yeah. No, I would encourage it. If you have somebody that's looking really bad, you've tried other intervention. Again,
Yeah,
for me,
that was after Vionib, Sildenafil,
Yeah.
CPAP,
Yeah,
MAG.
yeah.
So epi was given, and
That-
it was questioned 3 different times of why epi was given.
no, just haven't talked to me. But no, I.
Talk to the medical director.
Yeah, talk to me. Yeah. So yeah, if you've got somebody you're trying to hold off intubation and trying to stabilize their breathing, it's not used often, but it's a valid treatment to try to improve their breathing. Yeah.
So why is it so difficult to get them off the ventilator once they've been on?
Yeah, so once they get that support of the ventilator, they start to become almost like dependent on it. And it's hard to get them to, yeah, gosh, it's almost, they become dependent on it. It's hard to get them to where they're stable off of it and breathe normally. It's not a great description, but that's kind of what happens. So it can take many, many days, if not weeks, to get them off. I mean, if you have to intubate, you have to intubate them. I mean, it's just the way it is. I try if at all possible to hold off because I know it's going to be a very difficult road for the ICU to get them off of the ventilator. It's because they get kind of dependent on it. They're like, it's almost like they don't want to get out. Their lungs don't want to go off the ventilator. They get dependent on it.